This is the take-home message that I was going through right here. Hopefully that, can you see that okay, Jenny?
Yes, we see it perfectly. Thank you.
Okay. And so the bottom line is rehabilitation of respiratory muscle weakness has been shown in a variety of subject groups, and they can be treated by increasing respiratory muscle strength. Respiratory muscle strength training really began effectively in about 1966 when really respiratory mechanics got started. That was actually, for a historical sense, that was post-World War II. Arthur Otis and his group were part of the American respiratory group that helped develop adaptation to high altitude flying at Wright-Patterson Air Force Base. And Arthur Otis is the father of respiratory mechanics. And he worked with a variety of people, and in the 1950s developed the concept of work of breathing, and has also actually did some respiratory resistance training early on. And so a lot of training was focused on training the inspiratory muscles, making the inspiratory muscles stronger. And in 1996, after Tom Clanton developed his pressure threshold device, the expiratory muscle training started to become possible using pressure threshold devices. Generally using their device only went to 40 centimeters of water, which is generally less than about 50% of the maximum expiratory pressure generating capacity. Subsequently, there's been many peer-reviewed studies with some outstanding work done more recently. And as you can see from this graph, it's increased exponentially. And it's very exciting to see so many wonderful research groups getting involved in looking at how we can modulate breathing by modulating the pump by training the respiratory muscles, both for inspiration and for expiration. In the spring of 1998, our University of Florida group, using Denny Martin's method for training power training inspiratory muscles for ventilator weaning patients, we use that method of high intensity, about 75% of maximum expiratory pressure generating capacity with our first population of Gainesville High School band students. I'll mention that more later on, where we were fortunate to have Chris Sapienza as a speech pathologist working with us, and Chris was the one who was able to put that together and publish that in the Journal of Voice, and that was where we got our start. Why pressure threshold power training? Well, let's talk about the respiratory mechanics. And in order to do that, we need to make sure that we have our language. And our language is based on the classic diagram you'll find in most textbooks of various volumes that are associated with with breathing. The volumes that I want to focus on are two volumes right here. One is a functional residual capacity, which we call FRC. If you now relax, open your glottis, and at that rest position, no air is flowing in and out, your respiratory tract doesn't have to move, you are at FRC. And that FRC is kind of a balance point between the inward pulling force of the lung and the outward pulling force of the chest wall. And that is a point at which the respiratory system is in essence in mechanical balance. Now, if you notice that tidal volume, which is the volume of air that we normally bring in and out of our respiratory tract with each breath, we start, most mammals, except for horses, because I do teach in a veterinary school, but most mammals will breathe in and out above FRC. So in essence, an inspiration breath will go above FRC. And so in order to move away from FRC, you have to have an active pump. And that active pump is the inspiratory muscles. And those inspiratory muscles are going to generate a expansion of the thoracic cavity, and that is going to now bring the air up to a volume greater than FRC. But then as soon as you allow that muscle activity to stop, all the mechanical forces want to come back to this rest position. Hence, you have active inspiration and passive expiration. So we have our tidal volume moving up and down, breathing from FRC. what that breathing pattern looks like, if you make a pressure measurement, is that here I'm measuring, in essence, mouth pressure in this case. Here I have a portion of the breath. Now we define a breath as its inspiration and its following deflation phase, which is expiration. So in order for air to go in on inspiration, we have this portion of the breath, and then we define this portion of the breath as expiration. So this, starting with this inspiration, going to the next beginning of inspiration, this is one breath. Okay, in order for this part of the breath to occur, I have to have a pump that is going to expand the thoracic cavity, generating a negative pressure within the alveoli. That is going to produce the driving pressure. Now, air doesn't flow unless I have a driving pressure. If when I open my glottis and just let things rest, air does not flow, hence I have no driving pressure. If I now change the volume, I create a larger volume, which creates a negative pressure within the thorax. That is now going to drive air into the alveolar space, and I'm going to get inflation of the lungs. By the same token, in order for air to come back out, I also have to have a pressure gradient. And so that pressure gradient has got to be greater than atmospheric pressure in order for air to move out of the alveolar space. So hence I have, if my atmospheric pressure is equal to 0, to air go in, I have to have a negative pressure within the alveolar space. If the air is going to go out, I have to have a positive pressure within that alveolar space. And so for air pumping to occur with that tidal volume going in and coming out, that is going to be based on what happens with the respiratory mechanics, the physical properties of the system, and the muscle contraction. So on the standard, so if I were talking to my first year professional students, I would say I would present this as normal, quiet breathing. Inspiration is active, expiration is generally passive. And that is the dogma. And it is correct because during inspiration, we get an active phase. So if I record the muscle activity of the diaphragm, I get an active contraction of the diaphragm and lung volume increases as air flows into the system. Now, because the diaphragm and also the other muscles that are associated with the inspiratory pump have now expanded the thoracic system, that system now has to relax and stop its activity in order for the lung to deflate, to come back down to FRC. Now, that means that motor nerves have to drive those respiratory muscles, and they're rhythmically activated. And they're activated in a way and at a frequency, at a volume that is going to sustain blood gas values so you have enough oxygen for life and you can eliminate the byproduct or the waste product of metabolism, carbon dioxide. So this rhythmic movement of air the goal is to keep our O2 and our CO2 at the appropriate levels for life to occur. Now, breathing is a continuous ongoing activity. If you can't breathe, as one slogan says, if you can't breathe, nothing else matters. And so breathing is continuous and ongoing. The inspiratories must contract in synchrony, in a coordinated manner. During quiet breathing, it's going to produce enough inflation in order to produce the tidal volume that is going to be driven by not giving oxygen and carbon dioxide into the blood. You can also have an increase in that. So let's say I'm going to exercise or have some increase in metabolism or change my behavior in some way and I need more oxygen or eliminate more carbon dioxide. You can get an active respiratory event where I now facilitate this process to increase the amount of ventilation that's going to occur. Expiratory muscles generally are quiescent. If anything, they will contract a little bit in order to break and slow down the expiration. But in general, the mechanical process of bringing that lung system back down to its rest position is generally a quote unquote passive process, but it can be very quickly and easily activated and recruited, and you get active respiration. The inspiratory and expiratory muscles, of course, are like any agonist-antagonist muscle. They must not contract simultaneously because they're opposing each other. So hence, expiratory drive inhibits inspiratory drive inhibits expiratory drive. The rate and depth of modulation are the two things that you can adjust in order to adjust your ventilation. So to illustrate that schematically, we can see that inspiration, if this is the thorax, I'm going to have my diaphragm. And so when my diaphragm and other muscles contract, I'm going to elongate the thorax and I'm going to increase its circumference. What that's going to do is that's going to push the abdominal contents out, and I'm going to increase my outward force on my abdomen by the mechanical effect of pressure increasing in the abdominal pressure. And then during expiration, I have abdominal muscles and other expiratory muscles that can be activated to now compress that abdominal cavity, make the abdominal contents act as a piston to push up against the diaphragm, and hence have a relaxed diaphragm driven up into the thorax, shortening its length and decreasing its diameter. So this is going to produce an increase in thoracic volume, hence inflation. This is going to produce a decrease in thoracic volume, hence deflation. So I have my active portion of inspiration under rest conditions. This would be my diaphragm contracting in a crescendo manner. Then at the end of my inspiratory duration, the time required to do the inflation, I now have the diaphragm relax and I get an outflow of air during my expiratory duration. The volume of air that results in, I gotta move this here so we don't get that in the way. I have the result is a total breath time. And so when you measure the breathing frequency, you're measuring how many breaths in inspiration and its following expiration occur. And then we also measure the tidal volume. The combination of those two are going to give me minute ventilation. And minute ventilation is what's providing my inspiratory and expiratory drives that is going to produce the inflow of air, which is high in oxygen, the outflow of air, which is high in carbon dioxide. Hence, I get gas exchange of moving oxygen into the respiratory alveolar space and moving carbon dioxide out of the alveolar space. There are many models of this, so you can find a whole host of ways of looking at this. This is a way of looking at some of the muscles that are involved. Note that we have inspiratory muscles. Sometimes they're called accessory, but the accessory muscles are actually essential because they're coordinated, because you've got to have, for example, your sternocleidomastoid muscles to stabilize the upper rib cage as the lower rib cage is going to pull up and it needs to have a stable platform on which to work. Those intercostal muscles are very, very important because when the diaphragm contracts, if you don't have a stable rib cage, the diaphragm is literally going to pull the ribs in. You get paradoxical movement, which happens again in spinal injury or some other conditions. So we need to have a coordinated contraction of a variety of muscles that form the inflation phase or the inspiratory muscle pump. You also have a series of muscles that are predominantly the abdominal muscles and the intercostal muscles that can provide a active deflating force to assist the normal mechanical deflation of the lung. The point is, you have muscles that are multiple muscles that are working together to produce inflation, multiple muscles that can work together to produce deflation, muscles of expiration. And so if we look at what happens with our lung mechanical properties, if we use a balloon as our example, and I will demonstrate some of this in a little bit, what happens is that there are certain elastic properties, stretchability. So think of the balloon as kind of like a rubber band. As I stretch it, as I increase my lung volume, I'm stretching this rubber band or this balloon to a higher volume. What that means is that as soon as I stop pulling on it, or whatever volume I take it to, and now allow it to relax, it's got a recoil process that is going to occur, and that's going to be squeezing on the air that is inside that balloon volume. That is my lung elastic recoil. it produces an inward collapsing force, which increases the pressure, which now gives me a driving pressure for exhalation. And because I'm going to be going into more expiratory muscle strength training, I'm going to be focusing on the expiratory processes that occur. In addition to these elastic properties, I can also have an active compression of that respiratory system with those expiratory muscles. And so when I blow up my balloon, I have to apply a high pressure. And so I use expiratory muscle power generator in order to have an active pressure that adds to my recoil pressure, giving my net expiratory pressure, which has to move air through a resistor, which is the airways. And so their airways have tube properties. And so those tube properties actually have a resistance. And so when air flows through those tubes, there's two fundamental elements. There's the element of resistance of the tube itself, plus as air moves through, there can be a disruption of the laminar flow of that air into turbulent flow, which adds to the total resistance of the system. When we breathe, there are fundamentally three forces that oppose our breathing. There are resistive forces, there are elastic forces, and there's an inertial force or a pressure threshold force. Now, resistive forces are flow dependent. And so this would be kind of a little schematic showing that if I have a resistor, I'm going to have a system, a tube that will try to slow the air as it goes through it, or absorb some of the driving force energy as it goes through the resistor, and that is going to be dependent upon the rate at which air flows. Now, I also have a volume dependent system, because remember, think of the balloon. The greater I inflate it, the greater I have to stretch it. And so I'm going to have an elastic force that is going to be volume dependent. And in order to move that, the inertial forces, in order to get the whole system moving, I have to have respiratory muscles that are going to drive that pumping system. So we're going to use those three types of loads, which we refer to as respiratory loads: resistive, elastic, and pressure threshold, in order to understand how we make air move. And so Arthur Otis, as I mentioned previously, and his colleagues developed a model of a work of breathing that was primarily focused on inspiratory work of breathing. Now, at the very end of their early paper in the 1950s, they did present a one equation that tells us about how we can estimate the work of breathing for expiration. And so the difference between inspiratory work of breathing and expiratory work of breathing is the elastic element. So if you think about this, so when I do my inflation, remember I inflate my balloon, I'm now taking energy to expand against that elastic force. But now when I relax, that is potential energy that now allows it to contract back down on itself, and it produces a force. So it's the opposite for. So I'm literally getting in essence, a term that is now, instead of adding to the work of breathing, it actually assists the work and reduces the work of breathing based on the amount of elastance that's generated. What that results in, and then this is a when Otis did that work early on, they used sinusoidal models, which I'm going to use when I show you here in just a moment. But Nick Napoli and his research group here at the University of Florida have realized that we don't breathe as sinusoids. We breathe in a non-sinusoidal manner. And so a lot of their work has resulted in showing us that if you use non-sinusoidal breathing, you get some differences that are associated with the waveform, which is very, very important. But that's a topic for maybe another discussion. So if I take this and look at the three elements: resistance, turbulence, and elastance, and then the total work of breathing, I can model that and show that my total work of breathing, my total work, let me get this out of the way again. My total work of breathing is this blue line right here. And now when I take and look at the three different elements that come to making the work of, why bother with work of breathing? Well, the reason is that the work of breathing, you have, remember at the very beginning, one of the take-home messages is you have to generate enough pumping force in order to overcome the work of breathing to get air to move through the system and out of the alveolus. So for expiration, I've got my elastic component right here, which is stretched to, say, a certain tidal volume. Now I'm starting with a negative work of breathing. That means that it's going to be that I'm going to have a driving force automatically in place, ready to push the air out of the airway. Now I have to push it through the tubes, which is this orange line right here, which is the resistive element. And if I push it fast enough, I'm going to get turbulence. And so the combination is that initially, during exhalation, I get a really nice passive driving force from my stretch, but as I get later in the breath, I'm going to have some driving force that is in order, in essence, to get the air out because I'm going to have an increased work of breathing. And so you can see that air will flow rapidly at the beginning and it will taper off closer to the end. Now, let's give the patient, say, an asthma attack or something that is going to increase the airway's resistance. What happens now is that if I increase my airway's resistance, just this only, I now have an increased work of breathing, and it's going to take a much greater effort of the pump in order to get that air out of the system. So what does that mean? If I increase the resistance, say a good example is what we had going on during our COVID, is that a lot of us will wear face masks. Well, yes, I am enough of a geek that I measured the resistance of a face mask. And an N95 face mask has a resistance of about 12.5 centimeters of water per liter per second. So if I put a resistance on that's about equal to that, now I have a total work of breathing that from the very beginning, I dissipate and I use up my recoil, but I still got to get the air out. And so now how am I going to get this air out with this increased work of breathing? Well, I'm going to recruit active exhalation. And so when you ask people why they don't want to wear a face mask, it's number one, because it's hot. Number two, because it's humid. And number three, because it's hard to breathe. And what does hard to breathe mean? Hard to breathe means it takes physical effort in order to make the air move. So usually we recruit respiratory muscles, expiratory muscles, to push the air out. And in fact, if it gets really high, it takes a lot of muscle activity in order to generate enough muscle force in order to overcome the work of breathing if I have both resistance and turbulence that I need to overcome or a high expiratory force. But to quote Emerald, but wait, there's more. Work of breathing also requires that I generate enough force to also overcome the inertia of the system. And this is seldom modeled, and so this is what I've been playing with lately, is how can I model expiratory work of breathing and account for the inertia of the system. And sometimes that would be referred to, for those who are familiar with the term uh, intrinsic PEEP. That is, there's a certain amount of pressure that you have to generate that is part of the intrinsic system that is what we call positive and expiratory pressure. I have to generate enough pressure to overcome that inertia or the pressure threshold effect, and we can model that using the equation of inertia. Now, what does that mean? By the way, where we're going with that is this is a pressure threshold load. And so we can use this process to understand how expiratory muscle strength training really works. Because what we're going to be adding is we're going to be adding a pressure threshold right here to the respiratory system during exhalation and seeing how mechanically we can make that work. And why does that produce a training effect? So there's method to this madness. And so if I now take this equation, this relationship, if you will, and I plot that relationship, keep moving this thing around to keep it out of our way. If I look at what happens is that if I use like normal intrinsic PEEP, which is about 2 centimeters of water pressure, what I get is I get this line right here. Now, what does that mean? That means that I have to generate enough force to not just move the air out of the system, I have to move it out above and beyond this pressure threshold. So my work of breathing actually goes up during exhalation as a function of the pressure threshold that I must generate. Air will not flow unless you open up the pressure threshold. And so we can use various types of devices that can add to that pressure threshold. So let's say we take a small device, like a normal PEEP valve that you would find on a ventilator, and use a 5 centimeter water. Notice the difference in scale. So here I can generate, during normal breathing, I can generate enough force to get the air out. Here I'm going to have to generate more force. And again, that force has to be available to make air move out, as long as that to exceed that pressure threshold for the breath. Air will only be flowing when the pressure generator, the driving force, is greater than this work of breathing. Now, with expiratory training, we now apply even a greater respiratory load. So, for example, a 25 centimeter water load. Now, I have to generate and hold a pressure that is greater than 25 centimeters of water for air to flow. Once I open the valve, I now get air flowing, but air is flowing again with the normal resistance associated with the system. So I get an assist with my elastic recoil, but how am I going to generate enough force here in order to get that air to exceed the pressure threshold? Well, I've got to use muscles. I have to apply some sort of muscle force in order for that to occur in the air. And so I'm going to have that active squeeze process that is going to be applied in order to move the air through the system. Now, if I use, say, a pressure threshold load that is higher for power training, which is like greater than 50% of my maximum expiratory pressure, you again see that it's a matter of scale. I'm going to have to activate even more muscles in order to generate, or more muscle fibers to generate enough force in order to produce a driving force for air to move out that is greater than the pressure threshold that I have applied. So this 50 centimeter water pressure threshold has to have this much muscle force continuously through the exhalation for air to move out of the system, in addition to overcoming the resistors. So if I measure that as a pressure, I can show what it looks like if I'm trying to generate pressures during a pressure threshold or a high resistance, because both are loads. So both should require recruitment of respiratory muscles, and they do. There's a difference in terms of pattern. Now, the big difference in pattern is if I use a high pressure threshold load, what I have right here is I have a phase. So here's the beginning of the effort. You can see that there is no airflow until I reach the pressure threshold of the valve. Then the valve opens and I get airflow, but air's only going to flow as long as that exceeds the valve pressure threshold. As soon as that pressure threshold driving force drops below the pressure threshold value, the valve closes, and again I get no airflow, even though there's pressure generated in that process. And with the resistance, it's very different, reasonably different. And the fact is that with a resistor, it's basically a restricted tube. And so now if I have a resistor, I'm going to get airflow as long as I have a driving pressure. And it's going to be directly related to the pressure that I apply. So it's a airflow dependent load. But throughout the entire breath, I will get airflow. Now, I'm going to produce a demonstration that is going to show you how those processes work. So I'm going to stop share. And I'm going to show what I have hopefully been describing up to this point. We're going to start with a balloon. As I inflate my balloon, I have a volume that I expanded it to. And so this is inhalation, and then that's exhalation. Notice that the exhalation has pressure inside that is a result of this balloon having a collapsing force because it wants to come back down to its rest position, wherever that is. FRC, back to our language. So I'm going to have an FRC, breathe, comes back down. And so I have a mechanical driving force that is going to operate in terms of moving inflate, assisting my exhalation by bringing it back down to its mechanical rest position. Now what happens is now I can squeeze this. So I can use my expiratory muscles now to apply more force. And notice what happens. Everybody's worried I'm going to pop the balloon because I'm applying more force, and the pressure inside that balloon is increasing as a function of both the recoil plus how much squeeze I'm getting, producing a greater expiratory driving force. Okay, so I'm playing with a new gadget. And so what I'm going to do is I'm going to show you how resistive training differs from pressure threshold training. And I'm going to do it using this jury rig device. I'm going to close this off because I need to have this. Okay, so now what I have is I have an inflated lung. Here is a resistance trainer. Now the resistance trainer has a series of numbers that is based on the size of the orifice. The size of the orifice is going to be a function of the resistance. Now, if I put this resistance trainer on my breathing device and let my air go out, notice that it doesn't go out nearly as fast as if it's not there. We'll demonstrate that, of course. This takes a little tricky coordination. Now, if I don't have the resistor there, I get a much more rapid. So you can see that resistive training is going to apply a delay or obstruction to the exhalation. And if you now apply muscles to try to increase the force of driving it out, you will get an increase in expiratory muscle force. But at all times, air is going to flow. Let's see how pressure threshold valves work. Now what I have is I have a pressure threshold valve, similar to the EMST 150, just a lower pressure. And so what I have is I set this about, let's set it, what? This is a standard PEEP valve, so we'll set it about 15. And so what happens now is that there is not enough force here to let that air flow out. So if I decrease this, it's going to go up, but it's only going to deflate down to whatever this pressure is. So what happens now? I can't get the air out. So what's the body want to do? Apply muscle force in order to make that air flow out. Now the air will only flow as long as that pressure gradient is greater than the pressure of my valve. And that's how an expiratory muscle strength training valve works. So the EMST 150 or the 75 just have a higher pressure in order to do that, so that in order to generate enough force to make that air go out, I have to generate much more muscle activity. Now, why is that important? Glad you asked. So let's share again and go back to some diagrams. And because of the nature of the share, I'm going to have to come down to where my demonstration was. And if I actually measure things like pressure, airflow, perception rating, and volume, this trace right here is with a very high pressure threshold load. This trace right here, which is approximately equivalent resistive load. Notice that there's a difference in breathing pattern. In order to get airflow, I have to generate enough force in order to open the valve. And so you tend to have much shorter inspirations. We are flawed, lazy creatures. And so we try to minimize the amount of work we try to do on our respiratory system. And so what happens if I give a resistive load is I will lengthen the time available for the breath, in this case an inspiration, and but I can do that and get enough volume to sustain my volume by lengthening the breath and allowing my airflow to be lower, which hence has lower work of breathing. This is going to have a higher work of breathing because throughout the process, I have to generate enough force in order to overcome the pressure threshold value. And so if we use a measure of respiratory drive, which is called the inspiratory pressure time product, if I'm using this with an inspiratory load, what I see is my pressure time product, my drive has to go up in order to overcome the pressure threshold load. The drive does go up with a resistive load, but not nearly as much. Because the work of breathing is much greater with the pressure threshold load than it is with the resistive load. And so because the work of breathing is greater, my muscle forces have to be greater. Hence, I have to have a greater amount of muscle drive in order to make that pump function. So one of the things that we've recently been doing is I got to thinking that, boy, it'd be nice to be able to record a whole bunch of muscles at the same time when we were doing maximum expiratory pressures and maximum inspiratory pressures and inspiratory muscle strength training and expiratory muscle strength training. And so one of the things that I have observed when people do these processes is they change body position when they're doing these efforts. That means that they're activating muscles that are postural muscles and as well as the respiratory muscles. So I recorded from 7 muscles only because I had an 8-channel recorder and I had to have 1 channel for pressure. And so I recorded from the sternocleidomastoid. I recorded from the pectoralis, which is also lying over the upper intercostal muscles, but it's because of its surface electrodes, it's going to record primarily from the pectoralis. Getting closer where there is less muscle overlapping, I've actually started playing around with recording intercostal muscles laterally so that I can get less overlying tissue in order to get a better intercostal muscle recording. So we have sternocleidomastoid, pectoralis, lateral intercostal muscle, then rectus abdominis, which is one of the primary anchor muscles along the abdomen, external abdominal oblique, and then the parasternal muscles along the back. I recorded them in the thoracic region, and I recorded them in the lumbar region. When we did that and used an inspiratory muscle valve, that's about 75% of maximum inspiratory pressure and 75% of maximum expiratory pressure. One of the things that we have observed that I find very interesting is that you do activate the back muscles with both of those processes. You also activate differentially those combination of muscles so they're coordinated different. And so inspiratory training is going to activate, in essence, the neck muscles because it has to stabilize this upper rib cage for the inspiratory effort. You're going to get intercostal muscle activity there. You get much less abdominal muscle activity, and you get a difference in thoracic spine as the person is straightening their back in order to generate air to flow in, and a little bit less activity in a different pattern than you would see with expiration. Expiratory, you get much less sternocleidomastoid. You still get activity. You get some pectoralis activity, some intercostal activity, but of course you get strong abdominal activity and very strong spinal activity. If one looks at the raw EMG signals if this is a maximum expiratory pressure task, right here is when the expiratory effort begins. This is, remember when we do these processes, we take a deep breath in and blow out as hard as you can. So this part right here is the inspiratory priming breath, and this is the expiratory effort. A couple things to notice here is that you do activate the sternocleidomastoid, you do activate the pectoralis, you do activate intercostal, you do activate the rectus abdominis, the external oblique, and both the thoracic and the lumbar muscles. Notice also as the breath goes on, you get a crescendo of activity as in essence, the muscles continue to recruit more and more fibers to try to generate the force in order to produce an MEP pressure. Now, if we take 75% of that MEP and we have the individual do, say, in this case, it was a 50 centimeter water expiratory pressure that we asked them to, we set the pressure threshold valve at. Here's our priming breath. I get my inspiration, and then I do my expiratory effort, which lasts about 2.5 to 3 seconds, and I get some activity in the sternocleidomastoid, some activity in the upper chest. I do get intercostal muscle activity, but I get significant rectus abdominis and external oblique activity. But notice I'm getting both the back muscles that are being activated. And so what this tells me is that, first of all, a lot of other people have recorded muscles. So we're not the only ones who've done that. In fact, there's some great papers and studies that have shown that with expiratory effort, you get activation of a variety of muscles in the upper airway, the pharynx, in the neck. And in fact, that's really, really important because in order for that system to operate well, you need to coordinate those muscles and kind of wall up the airway so that you get a good flow pattern, channel for air to flow out of the system. But what this also tells me is that if you look at these muscles here, you're activating the core. The whole body core participates in breathing. And so one of the things that I've always wondered about and have been fussing about in my own lab is that we always talk about abdominal muscles for exhalation, diaphragm for inhalation. Well, that's true that they're dominant muscles, but they're not the only muscles. What happens when you do a strong effort is you activate the whole core. So one of the things that I think is important to realize when we're looking at rehab of the individual is that if I use a good, strong expiratory muscle training process, I don't only activate my abdomen, I activate my back and I activate my whole postural system. And so you have the potential of rehabbing the whole body core, not just individual muscles. And so when people ask me about how the system works, you're strengthening the abdominal muscles. My response is always, no, I'm strengthening the expiratory pump. All those muscles that contribute in a coordinated fashion to produce the expiratory forces, that's what you're training. And that's going to be something that starts at the mouth and goes all the way down to all of the entire body, the abdomen, the whole thorax, and people. Actually, it's fun to watch people do these sorts of things. As anybody who's ever done it, as soon as blow real hard and really use their whole body posture. That means that when you're doing expiratory training, you're training the whole body core. And so this, in terms of, say, physical therapy rehab, it becomes important is because now I have a body core rehabilitation that I'm working with instead of just my upper airway or expiratory breathing process. But we breathe with our brain. So let's go the next level. So how does this work? Well, it works by the fact that we have automatic control of our respiratory system, which is going to drive my respiratory muscles using my brain, and that is generated by the brainstem. So the medulla oblongata is providing those neuron activity, which is now going to drive the respiratory muscles through the spinal motor neurons and the cranial motor neurons that are operating in the head and neck region. And in fact, that neural network can be reconfigured for particular expiratory activities such as cough or swallow. This is what the neural network will look like. In terms of a computational model of that, And what I want to point out is the fact is that it's a network of neurons that is providing a coordinated output either for inspiratory activity or for expiratory activity, and it is using feedback from a variety of afferent systems in order to regulate this normal tidal breathing. But if we look at other model systems, we notice that we breathe with more than just our brainstem. Neil Cherniak, a long time ago, said that we spend about, awake, we spend about 70% of our time behaviorally breathing. That means that we have motor processes from higher brain centers that now descend and interact with our medullary control circuit. And that control circuit is now going to drive the respiratory pumping system, which is going to produce the ventilation. Remember, our goal is to keep our O2 and CO2 at physiological levels, but we also need to do that by monitoring a variety of processes that are going to tell the brain whether or not that is functioning. This is another model system that is in essence in a more schematic format. Basically, what we're trying to do is have an integrated respiratory motor drive, which is going to provide our minute ventilation, and we're going to use higher brain centers to coordinate that to produce a behavioral respiratory process. And that's what happens when I tell you to take a deep breath and blow out real hard. I'm activating a higher brain center system, which is driving my motor cortex, which is now driving my ventilation. Load compensation, hence, is the tissues and respiratory tissues in the breathing environments can impose a mechanical load. If I make the system stronger, then it's easier to compensate for the mechanical load of either the respiratory tract or the environment that they're exposed to. The whole point is to keep my O2 and CO2 at physiological levels. If I have an anesthetized condition, this is an anesthetized animal in which we recorded from lung receptors, monitoring lung activity. If I put a load on, what happens is the air comes out. Instead of my lung volume activity saying, okay, you deflated, it's saying, wait a minute, you've got inflation there. Hence, that's going to help drive the response to the load in a load compensation response. Physiological responses to loads, most people are going to adjust to load and compensate. They will adjust their flow pattern of breathing by adjusting flow, volume, and pressure during the loaded breath. They will modulate both the breathing times, be it inspiratory or expiratory. They will modulate respiratory motor drive. Tidal volume will be preserved. Alveolar ventilation will be sustained. And all species are going to minimize their work of breathing, except when they can't. And they will recruit behavioral load compensation when the brainstem can no longer handle it. And if the load is big enough, it's going to produce a negative affective sensation. In other words, I'll feel breathless. Respiratory muscle training, then, is respiratory muscles are like any other skeletal muscle. If I increase the load to that muscle, I can use low intensity loads with high number of repetitions to get endurance training. Or I can use high intensity loads with few repetitions to get strength training. And so strength training is more effective in the respiratory muscles because they're designed for sustained endurance. And so resistance training tends to will have various orifices. It'll be flow dependent. And patients will often learn to reduce their inspiratory effort. Now, it works very effectively if you have the individual target a specific flow rate. But most patients will sacrifice their airflow, sometimes producing hypoventilation, hypocapnia, hypoxia, and sometimes looks like fatigue, but it may not be. Pressure threshold training is training in which the stimulus is applied and you must always breathe greater than the stimulus. The EMST valve was designed by increasing the spring constant to either produce a 30 to 150 or a 0 to 75 centimeter water pressure range. And you use something that we measure maximum expiratory pressure and try to generate a training pressure that is going to be about 75% of that. And so with airway occlusion, I have the valve, way the valve works is that during inflation, similar to what I've showed previously, the valve is closed, no airflow. That's isometric. The valve opens, now I get an isotonic movement of the air, and so I get, and it's literally like lifting weights for the respiratory muscles. And so pressure threshold training is an effective way of training the respiratory system because it's weightlifting for the muscles. So what it looks like is this. So here is a schematic of an individual. I will put the valve on the individual. When I do that, and the individual is going to be given a pressure threshold of, say, 75%, if their maximum expiratory pressure was 67, that will generate a magical, just picked it out of the air, of course, wink, wink, nod, nod, that it's a 50 centimeter water pressure threshold load. What that means is that's 50 centimeters of water throughout the entire respiratory tract. Now, in order for air to get out, I have to have more than 50 in order to air to go out. So that means that during my exhalation, I'm going to recruit expiratory muscles that is going to generate enough muscle force to make the air go out and open the valve. Then I get airflow, and it's going to look something like what we showed previously is my expiratory muscles are going to work in coordination to generate that process. So, in summary, it's a spring-loaded valve that requires muscle work to isometrically produce isometrically before air flows. You get isotonic after you get the air flowing, but you have to have that muscle activity throughout the entire breath. Hence, you get more activation of expiratory muscles with pressure threshold loading. And so what you do is a strength training as all the muscles of the pump, and it generates those muscles. And when you get stronger, you feel like it's less effort to breathe, which improves respiratory function. Back to the band. The reason we did this is my son played saxophone in the Gainesville High School band. And he said, "Dad, how can I blow my saxophone stronger?" And I go, "Well, let's train the expiratory muscles." And so we did that with the wonderful help of the band teacher at that time, trained half the band with expiratory training, and half the band got control. We got this increase. So we got about, when in 2 weeks, we got an increase in pressure generating capacity in those band students. And so we found that the MEP increased, pressure generating capacity increased in a very short period of time. And their pressure generating capacity only increased in the trained group. Other people have, and again, the literature has grown from this early study. And I'm probably telling many of you something that you already know, is that you can train and get the individual to be stronger. So the take-home message is respiratory muscle strength is required to ventilate the lungs. If the respiratory muscle strength is inadequate to meet the mechanical demands of ventilation, the sense of breathlessness occurs, and that's called dyspnea. Rehabilitation of the respiratory muscle weakness is treated by increasing respiratory muscle strength. The use of high-intensity, low repetition pressure threshold training, so far as I've been able to see, is the most effective method of increasing respiratory muscle strength. And so, as research, if we knew what we were doing, we wouldn't call it research, but Hank the Cow Dog always reminds me, when you find a germ of truth, beware. Those germs can make you sick. Thank you to my many collaborators who've made all of this work possible. And thank you for all the funding agencies that have been generous in their support of my research over the last 45 years.
Thank you so much, Dr. Davenport. That was incredible. We think that this will be a great resource for many people working with many populations. We appreciate your time. We'll just take a few questions. If we do not get to your question and you have questions, please feel free to email me. Also, for those of you who would like a certificate of attendance, you can email me. I'm going to put my email in the chat right now. And I'm going to kind of combine these two questions. Someone asked if we're using EMST to rehabilitate speech and swallow. Should we be telling or cueing our patient not to engage these other muscles? And then the second part of the question would be, would recruitment of the SCM, for example, not be considered compensatory?
Okay, number one, the recruitment of the SCM is compensatory because it helps stabilize the whole respiratory system. Number two, you want the whole system to be trained. And the reason you want the whole system to be trained is because, as I understand this concept, which is very vague to me, is what's called support and control. What happens is that my pump generator actually can shift the support portion down so that you don't have to use the larynx as much to regulate your pressure, your outflow pressure. You actually have a better support for in essence for support for your pressure generator. And so yes, you want to be able to train the whole system because that is one of the things that is going to be more effective in producing good expiratory airflows.
Yes. And just to finish off, Dr. Davenport, many people outside of the speech therapy world always comment that EMST is a speech thing. Can you tell us why it's very much applicable to other clinical specialties?
Hopefully, well, expiratory muscle, then that's why I put the slide up of we train the core. And so all of my all of my physical therapy colleagues will tell you that you train like you play. So if you want to have a better pressure generating capacity, you want to train the pressure generator. If you want to have a better core pressure generating capacity, maybe a better pressure process in terms of the abdominal core, you're going to be training, you're going to be activating multiple muscles other than, and the reason it's confined to a few muscles is those are the only ones we recorded from. There are a lot of muscles that we activate that, in fact, I had a 16 channel unit that I really wanted to use. I actually have another unit that was 64 channel, but I didn't get that study done.
Or,
I want to record all these daggone muscles because I'm sure that when I activate the system, I'm activating the whole core. And so I really believe that in terms of you want to have in essence, a rehab of a person's core, even part of their posture, it's been that you wanted to use expiratory training will be effective.
absolutely. And somebody did ask about the pelvic floor muscles in the side chat. And I can tell you off the record, we've done some studies with SEMG and have seen activation in those muscles. And there are some ongoing studies currently that we're really excited to see the results of. As soon as they're available, we will share them. And for everybody asking, there will be a recording available both on our website as well as on our YouTube channel shortly. And if your question was not addressed, please feel free to reach out to us via email. Dr. Davenport, thank you so much for your time and your knowledge.
Thank you very much. It's
We
a
appreciate
great
it
privilege.
very, very much. Thank you. Have a good day, everyone.
Thank you.